Hi guys, my name's Aisha. I'm a dual qualified foundation doctor and I'm also the programme lead for the OMFS Survival Guide. This talk is on the A to E assessment, something that's really important as unfortunately many of you will have to see and assess an unwell patient at some point during the year, and hopefully this talk will teach you about the components and kind of how to perform it thoroughly. So the aims and objectives of this talk are to hopefully help you understand the components of the A to E assessment and the principles of the process and how to carry it out. We would also like you to be able to apply the principles when you're sort of managing patients and to also understand the immediate treatment of certain issues that might arise as part of the A to E assessment, and to also have a think about some of the differential diagnoses of the acute presentations that you might be seeing. So the principles of the A to E assessment. Most people tend to know that it stands for airway, breathing, circulation, disability and exposure, but actually understanding kind of what the point of it is. So it's a systematic approach, and it basically means that you do the same thing for the A to E assessment regardless of what you think the diagnosis may be, because it's there to provide a structure for you to be able to check the same things every time and to identify and treat issues that are, really life-threatening in the order that they could potentially kill the patient. So the aim of the A to E assessment is to improve the clinical outcome of the patient. It doesn't matter what the diagnosis is. And it's not even there really to find out what the diagnosis is. I mean, you may well do during whilst you're kind of going through each component, but it is there to treat and rule out the life-threatening pathologies in the order that they will cause a problem. So that is why the airway comes first. An obstructed airway can kill someone in minutes. However, the circulation can come above airway if there's obviously a catastrophic hemorrhage. The other thing is you need to be aware, if you've got an unwell patient, you do need to call for help early. You don't necessarily need to finish the full assessment. If you're really concerned by an airway problem, speak to anaesthetics or your senior early on. Whilst they're coming over, you can finish the rest of your assessment and report back to them once they're there. And you need to be fixing some of the issues as you come across them. So don't do the whole A to E and then go to prescribe or do some interventions. So you want to fix things as you go along. So, for example, if the patient's got saturations of 85%, apply the high flow oxygen there and then move on. Don't get to the E and then put the oxygen on because the patient's sats could easily have dropped to like 70% by that point. Or, in the same vein, if the patient has a low blood pressure, give them a fluid bolus and then move on to the rest of your assessment. So I just wanted to go over observations and kind of how to interpret them, because I think it's really important to know the significance of deviations in the normal obs and what the normal values are as well. These are the adult ones as well, and that's why I put adult observations there, because children have different normal values. So in hospital, these are all going to be on a computer, and these parameters are what make up what we call the NEWS score. It stands for National Early Warning Score. So any abnormal observations will generate a score. So the higher the score, the more abnormal things are and the more unwell the patient is. So you will often get phone calls from nurses saying, oh, patient in bed 13 is scoring a 4 or scoring a 7. So the higher the number is, you know that there is a problem. But when they give you a number, they don't often give you the observation. So it's important to ask for what the actual observations are as well. So I'm just going to go through each component. So oxygen saturations should be more than 96%. In patients with COPD who retain carbon dioxide, and this is only some patients that have this problem, not everyone with COPD is a retainer. So they will have a lower normal saturation of oxygen. But like I said, it's not the case for everyone. So if you have a patient with COPD and their sats were above 96%, say pre-op or something, and now they've suddenly dropped to 88, don't assume that that's just because they're retaining carbon dioxide, because they weren't. So your respiratory rate, that also needs to be looked at with the saturations. So if the respiratory rate is high, but the sats are normal, this means that the patient's having to work a lot harder to maintain those saturations and that there is a problem there. If the respiratory rate is low, this is also a problem. In hospital, probably one of the most common causes of a respiratory depression is medications, so opioids, things like morphine, oxycodone. So check the patient's drug chart. The heart rate, if that's high, is what we refer to as tachycardia. This could be due to quite a few things, and as part of this, we do go over this in a bit more detail in the fluid prescription talk, but I think it is important for you to know how the body reacts to either a low blood volume or blood loss, because this is going to be something that you will see. So one of the first signs is that your heart rate rises because your heart is trying to pump around the same blood volume to maintain the blood pressure. So if you've had a bit of a bleed or you're quite dehydrated, your heart rate will rise. Some cardiac arrhythmias, such as like atrial fibrillation and things, can cause a fast rate, but you would only be able to tell that from an ECG. The patient could also be in pain. That might be why the heart rate is a bit fast, or they may be anxious. But you must always rule out a medical cause first. You know, if you see someone with a high heart rate and you know that they have anxiety, don't just presume that, oh, they're having a bit of an episode. You know, do investigate it as if it is abnormal. If the heart rate's a bit too low, sometimes that is physiological in someone who's very athletic. It can also be due to certain arrhythmias, and sometimes patients that are on medications such as beta blockers or other meds to control the heart rate, like digoxin, can also have a low heart rate. The low heart rate is called bradycardia, if you hear it referred to as that as well. So going over to the blood pressure, this is really important because you need to maintain your blood pressure to perfuse your organs. So it's really important that you know that your body will do everything it can to maintain your blood pressure. So the moment the blood pressure drops, it means that the patient is becoming unstable because the body's done everything else it can to try and maintain that blood pressure. So either increasing the heart rate or sometimes, vasoconstriction to the peripheries to try and maintain the blood pressure. Thinking about hypertension and what could cause a high blood pressure. So hypertension isn't uncommon. So it's also important to know what is normal for that patient. And you can find this in GP records or kind of look at what their observations have been like, because someone with what seems to be a normal blood pressure, so it might fall within those normal volumes on that slide, might actually have lost like a significant amount of blood or be really dehydrated if their normal BP is like on the higher side. So if that's low, they'll need a fluid bolus or blood if they've lost blood as well. So once your blood pressure has dropped, like I said, it could be due to losing blood, that's stage 3 hypovolemic shock. Or the other cause as well can be sepsis, because the toxins from the bacteria kind of just cause you to vasodilate peripherally and your blood pressure drops. If both the heart rate and the blood pressure are abnormal, so usually it would be a high heart rate and a low blood pressure, and like I said, that's because the body is working really hard to try and pump the blood around and maintain blood pressure to your organs. We refer to this as something called hemodynamic instability. So this is important. The patient is very unwell and it needs to be addressed urgently because it means you're not managing to maintain blood flow to the organs. And just a quick note as well, it's not that important, but it's just something to be aware of. There is something called the pulse pressure, and your pulse pressure is the difference between the systolic and the diastolic pressure. So as these numbers come closer together, basically in conjunction with a raised heart rate as well, that is a sign that the patient has a reduced blood volume. Like I said, it's not something to worry about too much, but it is something that you should be aware of when you are looking at the blood pressure, because the diastolic, so that number should be 25% or more of the top number. So say if you've got a patient's blood pressure of like, the systolic is 120, the diastolic should be, 90 or less. If those numbers start to creep too close together, that means that there's a bit of a problem. Thinking about temperature, so your body raises your body temperature in an attempt to try and kill the microorganisms, but you can also get cold sepsis. So just because a patient doesn't have a raised temperature and they are unwell, it doesn't rule out sepsis. Other things that could cause a low temperature could be hypoglycemia, if the patient's intoxicated with alcohol, hypothyroidism, and some neurological disorders as well that cause like autonomic dysregulation, like MS. So those patients could run a slightly colder temperature. And the other thing that we look at is the conscious level. So that's formally assessed using the Glasgow Coma Scale, GCS, but in a situation like when we're doing an A2E assessment, we would just use the NAVPU system. So that stands for newly confused, alert, voice, pain, or unresponsive. So yeah, it's basically, are they confused? Are they alert? Are they only responding to your voice? Are they only responding to pain? Or are they unresponsive? So I'm now just going to go through each component of the A to E assessment and just explain what you should be checking for and interventions and investigations that we can order for each area. After this, we'll go through some cases just to put those into practice. So looking at the airway, very important to oral and maxillofacial surgery. Obviously, most of the operations that we do are in this area and can cause airway compromise. So the first thing that we want to be looking for when you're first asked to see an unwell patient is you want to actually assess whether or not it's a cardiac arrest. So like I said, we always do this end of the bed assessment. If the patient is unconscious, you want to go to your BLS protocol. Sometimes it is surprising you will get phone calls saying, oh, this patient has a new score of this, and actually they are unconscious and really, really unwell, and they shouldn't actually have called you first. But it does happen, and it's always really important to consider that. So if the patient is conscious, we'll proceed with your A to E assessment. So it is worth actually asking for the crash trolley to be nearby, just in case you need any of the equipment, because the crash trolley has things like nasopharyngeal airways, Goodell, the oropharyngeal airway on there as well. It is important to note that the A in the A to E assessment does come with C-spine control as per the ATLS protocol, but this is only really applicable to patients that have had trauma. But it is important to remember that patients do have falls on the ward. So if you're called to see a patient who's had a fall, remember the C-spine control. The first initial airway check that we do is we will check, can the patient speak? So, you can introduce yourself to them and ask them to tell you their name and their date of birth. If they can speak clearly, generally their airway is patent. If the patient has a tracheostomy, they might not be able to speak to you, and this becomes a little bit more difficult to assess, but we'll be looking for other signs of them having an airway or breathing issues, such as leaning forward, some cyanosis or any other problems like that. We will talk about tracheostomies a little bit on the next slide. We also want to be looking for any airway obstructions. So, is there any neck swellings? Are there any objects inside the mouth? Has the patient vomited? Do not blind finger sweep the patient's mouth. I'm sure you're all aware of this from doing your BLS courses, but sometimes you can risk pushing things further back. So only try and remove things from inside the mouth if you've got easy access. You want to be listening for any additional noises. So stridor is a high-pitched noise on inspiration, and this is an emergency, and if you hear this, you absolutely need to call for help, because it means the airway is already narrowed. If you think, as the airway becomes narrower, the pitch becomes higher. If any of you play wind instruments, if you think, as the narrower areas will produce more of a high-pitched sound. Stertor, so that's a snoring noise, and that's an upper airway obstruction, so kind of more like around the soft palate, and the upper area of the pharynx. This is easier to sort with a nasopharyngeal airway or the simple interventions. So you would do those interventions first, but if you ever hear stridor, you absolutely must call for help. We also want to make sure that the patient has continuous oxygen saturations monitoring on, so they should have the finger probe or an ear probe on as well, so we can keep an eye on that. In terms of interventions, so if the patient has an airway obstruction and you can't sort of manage it easily, you must call for help. So say if it's overnight out of hours, there's always an anaesthetist on call or an airway team on call, and your own registrar as well. High flow oxygen, it's available at every bedside, at every A&E area, and you'd be applying 15 litres through a non-rebreathe mask. Other sort of simple interventions you can do is a head tilt chin lift, so that can be used to open an airway. The jaw thrust must only be used if a patient's got a possible C-spine injury and it is painful, so no conscious patient will let you do it. So it would only be if the patient is unconscious. Thinking about sort of simple airways that you can use, so the oropharyngeal, the Goodell airway, if a patient can tolerate that, because as you can imagine, it goes into the mouth, passes past the soft palate. If they can tolerate that, they're not protecting their own airway because they don't have a gag reflex, so you need to be thinking about calling an anaesthetist, because it may need that those patients require intubation. A nasopharyngeal airway is as it sounds, so that goes through the nose. It's really important, so if you've got a trauma patient, if the patient has a suspected base of skull injury, or anything like that, you shouldn't put an NP airway in just in case you poke it upwards. We don't want anything going into the brain. And it's always really important to note that once you've performed an intervention, so for example, patient sats are low, you put oxygen on, recheck the sats, make sure that they have come up. So just a very quick overview of tracheostomies. Most of you who work in units with patients that will have tracheostomies due to major head and neck cancer surgery you are sent on an airway course. But this is just to sort of explain a little bit to you about what they are and the different components of them. So they are used to provide an airway, either because the upper airway is obstructed due to a swelling. We do them by choice in a lot of our patients who are having the major head and neck surgeries, just because they're going to be very swollen, and often the free flap can be quite large. So we do sort of worry that the patient might not be able to maintain their own airway. Patients may have damage to the cranial nerves or the brainstem that affects their upper airway, so again they may have a tracheostomy, and they are also done for patients who have been intubated and ventilated in ICU for quite some time as well. So as you can see from the picture, the tube goes through the skin into the neck and into the trachea, and there is a balloon around that tube that you can see there that is labelled cuff. So when that's inflated, it blocks up the upper airway from the trachea, so the patient will breathe exclusively through that tube. When we think, the swelling is resolving, we want to kind of trial whether or not we think the patient could breathe through their mouth, we take that cuff down, because then that opens up the trachea to the upper airway. We want to see if the patient can kind of breathe past it and manage their own saliva and other secretions. The picture on the top right is just a picture of a tracheostomy tube. It's the one that we use in our hospital, so it's just so you know what it looks like. And then the one on the bottom just kind of shows you the different components. So you can see you've got the outer cannula, so that is the main bit that goes into the neck and is sutured in. Where it says inner cannula, so that inner tube is there for you to be removing and cleaning. Not you personally, usually the nursing staff are responsible for that, but you can get like dried secretions clogging it up. So having the inner tube there means that if there is a problem, if that gets blocked, you just remove the inner tube. We're not having to take the whole tracheostomy out. So if the patient seems to have, an airway issue, or you're worried that the trachea is blocked, you can remove the inner tube, you can clean it. You can also pass a suction catheter, which is a really long bendy suction, into that tracheostomy tube and see if you can suction any mucus plugs. Usually the nurses have done that because all of our patients with tracheostomies go to specialist head and neck wards with specialists, head and neck trained nurses. Okay, so moving on to the breathing assessment. So you want to be counting the respiratory rate. You want to count that over roughly a minute. You can look for any peripheral or central cyanosis. So that's, patient maybe turning a little bit blue. Central cyanosis we look for underneath the tongue. You want to look at the patient's chest, so expose it and have a look to make sure it's expanding equally. And you can also have a feel for the trachea if they don't have a trachea tube in, and just check that it's central and it's not going off to one side or the other. Listening to the lungs, we don't expect that you would know how to use a stethoscope. If you would like to learn, speak to your registrars and practice wherever possible. I've put the listen to the lungs because it is part of the breathing assessment, but we understand that you probably won't be happy doing that. So thinking about investigations and interventions that we may do for a possible breathing problem. So again, we can apply high flow oxygen. Chest x-rays, so we take those to look for pathologies such as like pneumonia, we can see fluid in the lungs, which is pulmonary edema, or a pneumothorax, which is air between the lung and the chest wall. The arterial blood gas, so this is an immediate blood result. So the normal bloods that we take from patients' veins, we send those off. They can take 2 to 3 hours for the lab to give us the result back. An arterial blood gas is taken, as it sounds, directly from usually the radial artery on a patient, and you take it to an analyzer and it spits out like what looks like a shopping receipt and kind of gives you some results. We will have some examples of arterial and venous blood gas results and things in some of the other talks, and we'll be going over how to interpret those as well. But yeah, so the main indication of taking an arterial blood gas would be if the patient's saturations were low, or if they were breathing very quickly or slowly, just to check what their oxygen is like in the blood and the carbon dioxide content as well. If their SATs and blood, their breathing rate and everything is fine, but they're still unwell, you would then take a venous blood gas, because that shows up the rest, everything else that you see on an ABG, but it's just because it's from the vein. The oxygen and the carbon dioxide aren't quite as accurate. If you haven't already, sit the patient up. Really easy thing to do, because it will take some pressure off the anterior chest wall and it'll help them get their breaths into the bases of the lungs and hopefully improve their oxygenation. So giving patients salbutamol nebulizer. So if they sound wheezy and you're suspecting that they're having an asthma or a COPD exacerbation, you can give the patient a nebulizer. So it's basically salbutamol, but rather than them having to coordinate breathing it in via the inhaler, it's kind of just put onto an oxygen mask through a chamber and they just sort of breathe it in at their leisure. It will help relax the bronchioles because the wheezy noise, like stridor, is caused by narrowing. Okay, so now onto circulation. So all of these things you can do very easily. So you want to be feeling for the pulse at the risk, and you want to sort of have a feel for sort of 15 to 30 seconds. You want to know what the rate is, but you also want to be checking if it's regular or irregular. If the patient does not have a pulse and they are obviously unconscious, you need to be putting out a 2222 call for a cardiac arrest. If the heart rate is too fast or too slow, I would ask the nurses to do an ECG to look for any arrhythmias. We don't expect you to be able to interpret those, but if the nurse gets the ECG, you can take the print out to one of the medical doctors and ask them to check it for you. Checking the blood pressure. So as we said earlier, abnormalities in blood pressure really should be taken in context with the patient's usual readings and their clinical condition. So if the blood pressure is low, and you know it's low and we're a bit worried, then we can give them what we call a fluid bolus. So we would give them 500 mils of something either like Hartmann's or plain saline over less than 10 minutes. And then we want to recheck their blood pressure to make sure that it's come up a little bit. If you've got any patients, if your patient has like known kidney failure or heart failure, we don't want to give them that much fluid because it means that they're not going to be able to clear it as well. So we would give them half that amount. We give them 250 mils instead. If there's no improvement after that first fluid bolus, I again would be calling for help. We also want to be checking the patient's capillary refill time, so you can press on the fingernail for 5 seconds and check how long it takes for it to come back to being pink, and you can also press on the sternum as well. And we'd also take the patient's temperature. Some people do this as part of disability. I always just take it as part of circulation, because if the patient's got a raised temperature and their BP is dropping, could be sepsis, all kind of falls within the same sort of area of this cause of the circulatory collapse. So as I said, we wouldn't expect you to interpret an ECG, but knowing the indication is important. So it's basically a heart rate that's too fast, too slow, or a new irregular pulse. If the patient is confused, it's important to take one, or if they're short of breath. It's non-invasive and it provides lots of useful information, and most doctors would definitely like to see one when they come to review an unwell patient. So to give the patient these fluids that we were talking about, the patient does need IV access, so they need a cannula. Ideally, we would put like 2 cannulas in, like one in each ACF. But if you can, at least just put one in. And off the back of that as well, we'd want to be taking some bloods. So at a minimum, we take a full blood count, U&Es, liver function tests, coagulation screen, CRP if we're suspecting infection. And as I said, we can take that venous blood gas as well if their SATs and their breathing rate is okay. We'd also take any others that are relevant to the past medical history or relevant to the complaint. So there is a blood test called a troponin that we would take if the patient's complaining of chest pain, because that could be an indication of whether or not the patient's having an MI. And if the patient has a temperature, then we would also take blood cultures as part of the sepsis 6. So fluid balance. If the patient's NG fed or has a catheter, they should have a fluid balance chart. However, this isn't always there, because if you are to speak to the medical team, the med reg will almost always ask you about what their fluid balance is like if you call them for help. And the other kind of quick thing that you can do as an investigation, so if the patient has a high temperature, again, as part of the sepsis 6, we want to investigate for a urinary infection. So you can ask the nurses to do a urine dip. So this is basically where you get a urine sample and it's a little stick, and they put it in and it changes colour depending on what is in the urine. We'll go over how to interpret those in another talk as well. So now on to disability. We want to see, is the patient newly confused? Are they alert? Are they only responding to pain, or only responding when you speak to them, or are they unresponsive? You want to be checking the pupils, so you want to shine a torch into each pupil. You want to check, are they an equal size, and are they responding to light? Any kind of abnormalities with their pupils, depending on kind of how the patient is and what they're presenting with, sometimes, that could be a sign of an intracranial bleed or something else that is pushing on a nerve, which we don't want. So again, that's something very important to note and to escalate to a senior. Hypoglycemia, so this is a really common cause of reduced consciousness and various other symptoms actually. So if you've got the arterial or the venous blood gas, the glucose is on that result, but if you didn't get one of those, then you can ask the nurse to take a capillary blood glucose sample and you can treat that as appropriate. If the patient is hypoglycemic, follow your hospital protocol for treatment. And the other investigation, so as I said earlier, if the pupils are unequal, that can be a sign of what we call a space-occupying lesion in the brain. Then we would consider doing a CT CAD after discussing with a senior. And the last component, exposure. So this is just looking for anything else that may be causing the patient to be unwell that we've missed. So, the vast majority of our patients will have had an operation, so check their surgical site. If they've had a free flap, check the flap, look at the wounds for any infection, any signs of bleeding. You also want to, we are kind of trying to do a top to toe assessment. So I actually always start at the feet and work my way back up so I don't forget anything. So we would look at the calves for any swelling. Are they equally swollen? Is it unilateral? Because, we might be thinking about if they've got bilateral edema, that could be a fluid overload. If one calf is more swollen, it could be DVT. You want to be checking their abdomen for any sort of distension or tenderness. Again, we don't expect you to be able to perform a full abdominal examination, but, do look for, is it distended? Is there any bruising everywhere? Have a feel to see if, the patient's complaining anywhere it's specifically tender. And then you kind of just want to look over the patient's entire body for any rashes, swelling, bruises that are abnormal. Any further investigations and interventions is just going to depend on your findings in this area as well. So calling for help, who do you call for help? I thought this was a useful slide to include. It does depend on where you work, but it is important to know that there are different teams in the hospitals that you can call if one of your patients has an issue. Your MaxFax Reg is generally going to be your first point of contact, but out of hours, they might not be in the building, and so there are many other teams that you can call whilst they're on their way. So as you can see here, if there is an airway problem, you'd also want to be getting the anaesthetist involved. If you've got a medically unwell patient who's kind of relatively stable, you want to speak to your own reg plus the medical registrar. If you've got a patient that is quite unstable, depending on where you work, some of you will hopefully have critical care outreach teams. They are fantastic. They are composed of advanced nurse practitioners who will come along and kind of sort of do an A to E and help you out with stabilising your patient. We don't actually have a critical care outreach team where I work, so I would just be on the phone to the ICU reg for help. And then, as you can see, there's a couple of other things. The urgent imaging I thought was useful for you to know. If you order an urgent chest x-ray, you must call someone and tell them that you ordered it, otherwise it just goes on a general list. So you always need to speak to radiology about any imaging that you've ordered, otherwise it won't get done there and then. And there is just a summary of the A to E assessment, what to check, and the interventions and things. Well, now I'm going to move on to some cases just to kind of put those aspects into practice and kind of go through a few pathologies that you might find. So here's case one. So you are the nighttime DCT or SHO on call, and you get a bleep from one of the nurses on the head and neck ward, and she tells you that bed 12 is confused and has a new score of 3. There's not much detail here, and this unfortunately represents quite a lot of the phone calls that you will get. So it's always important to know, and we do reinforce this throughout this course, but there's a lot of information that you can get out of someone over the phone before you even go and see the patient that may direct you, to kind of certain things. So you want to ask for the full observations to see why this patient is scoring a news of 3. And you also want to have a little look at your handover to see if this patient's got any sort of relevant past medical history, if they're on any medications, or if they've got any recent bloods as well. So you have a little look at your handover and you can see that this patient is 11 days post-op from having a right hemiglossectomy and a left radial forearm free flap. You ask for the full observations over the phone, and here they are. So the patient is saturating at 97% on room air, which is fine. Her respiratory rate is 16, which again is normal. Her temperature is 38.2, which is raised, and her heart rate is also raised as well. Her blood pressure appears to be within normal limits, but with the raised temperature and the raised heart rate, it's always important to think about sepsis. But do keep an open mind, and always remember the whole principle of the A to E assessment is so you do the whole, like you do everything every single time so you don't miss anything. So you're having a look for a little bit more information, and you can see that this patient has some bloods done 3 days ago. We've got a bit more of a detailed talk on interpreting blood tests, but briefly, so her white cells are raised. This could be an infection, but this patient has also had a really big operation done, and white cells are not just an indicator of infection, but inflammation as well. And so if you have a look at her bloods from the day before, we'll say that these are improving. And it's the same with the CRP. It's raised, but if it's improving, then that's fine. The patient's hemoglobin is 102. You can see the normal range there is 115 to 165 for a female. Again, this patient had a very big op. And then if we look at the past bloods, we can again see that this has been improving, so it's not of much concern. The sodium is 146. Again, I've highlighted that in red, and you can see that's slightly out of the normal range. This could be an indication of dehydration, because as your blood volume reduces, the sodium becomes more concentrated. So often a high sodium is a sign of dehydration. But these bloods are 3 days old, so you'll need some new ones. So you're again having a little bit more of a read through the notes. So you can see that the patient is 11 days post-op. She did have a tracheostomy, which has now been removed. You might see this being referred to decannulated or decannulation 4 days ago. So that means that she won't, the hole where her tracheostomy was, it was only 4 days ago, so it won't have healed over yet. Her past medical history includes type 2 diabetes mellitus. It has hypertension, and she also has osteoarthritis. And the medications that she's taking are metformin, ramipril, and amlodipine. So going into our A to E assessment, so like I said, we always do a quick end of the bed assessment. So this patient is confused and disorientated, so you can't really get much of a history from her. Thinking about her airway, it is patent. She's speaking, but she's clearly confused. You can see that she's got a dressing on her neck where the tracheostomy tube was removed. And when she's kind of saying random words, you can't hear any additional noises such as stridor or stertor either. Assessing her breathing, so you count her respiratory rate, and this is now a little bit higher at 20. The patient's chest, when you kind of have a brief look, it does look like it's expanding, but like bilaterally, and it's on both sides, and it's fine. And you also have a little look for any cyanosis, and there's no signs of any peripheral or central cyanosis. Her circulation, so you check a capillary refill time at the fingers and on her sternum, and that's 3 seconds, so is pretty normal. You take a pulse at her wrist, and it's 105, so it is raised and it's regular. So based on that, we're going to ask the nurses to take an ECG. Her blood pressure is 111 over 84 now, so that is normal. However, like I said, we always consider what is normal for patients. So if you look at her previous observations, you can see her blood pressure has been sat around that, so we're like, okay, that's fine, that is normal for her. So we're not going to give her a fluid bolus at the moment. You do note that the patient doesn't have a cannula. We are thinking about sepsis due to that raised temperature, and we want to give her some antibiotics. So we are going to pop, like I said, ideally 2 cannulas in, 2 like wide bore ones, 1 in each arm. The patient has been urinating normally. I think the nurse it says that she's unsure when the patient last passed urine. She doesn't have a catheter in, so that's something that we can consider as well. So thinking about the information that we've got so far, I think the airway and the breathing was mostly fine, but the circulation, there was an abnormality in the sense that the patient's heart rate was a little bit high and she has a raised temperature. So thinking back to what our investigations and interventions would be, so the patient is confused and she also has a temperature, so this definitely warrants some bloods to be sent off. So we're going to cannulate the patient, and we can take some bloods out of that cannula. Because she's confused, even though we think we do think it is likely due to sepsis because of that temperature, we just want to make sure that there's no other causes. So what we're going to do is we're going to send off what we call a confusion screen of bloods. So what you are seeing on the screen, the venous blood gas, a full blood count, user-needs, coagulation screen, liver function test, thyroid, bone panel, B12 and folate, CRP and blood cultures is part of the confusion screen. Don't worry about memorising that. Most of the hospitals will have this as kind of like a set that you can order. So because this patient is unwell, like I said, we would take a venous blood gas and it is basically just taking a different syringe and it's analysed within minutes. So it gives you really important immediate information. So you'll be able to see the patient's glucose on there, ketones because she's diabetic, the pH of the blood and a haemoglobin as well. The blood cultures, they do need to be sent because the patient has a temperature and they're part of the sepsis 6 protocol. We do, again, have a whole talk on sepsis, so I won't go into too much detail. And if you can, you should be taking the blood cultures before you give the IV antibiotics, but you shouldn't delay giving antibiotics, just, if anyone's struggling to get blood cultures out of the patient. We also want to dip the patient's urine. As I said earlier, it's it's a very quick bedside test. We just get a urine sample from the patient and then we use a stick that tells us, whether or not there's glucose in there, if there's white cells, blood cells, and various other things. Because this patient is tachycardic, we also need an ECG. So moving on to the last bits of your A2E assessment. So disability, we already knew the patient was confused. The glucose, so the venous blood gas comes back and we'll say that the glucose is 12. But her pupils are equal and reacting to light, and that's what that PERLA stands for. On exposure, patient's calves are soft and non-tender, and you're just sort of having a bit of a feel of her tummy. It is soft, and she seems to react as if she's in a bit of a pain when you kind of palpate what we call the suprapubic region. So that's kind of the middle of the bottom end of the abdomen. And you have a look at her operative site and the flap. They're both absolutely fine, and there's no rashes, no swellings or any bruises elsewhere. So you've called for help and your reg has said, yes, this patient is likely septic and we need to do the sepsis 6. So we have a whole talk on this, but it is really, really important because it's probably one of the most common causes of a patient being unwell that you're likely to see. So what we do is there are 6 things. That's why it's called the sepsis 6. So we give oxygen to keep the patient's SATs above 94%. We take blood cultures. We give IV antibiotics. We give fluids. We measure the patient's lactate and we measure their urine output and take a urine dipstick as well. The sepsis 6 can be remembered by this really easy mnemonic, Buffalo without 2 Fs. So the B stands for blood and blood cultures, which we take. The U is for urine dip and urine output, again, which we take. The fluids we give, the antibiotics we give, the lactate we take. Again, you would see that on a venous blood gas. And we give oxygen. So if you remember Buffalo and give 3, take 3, that basically covers what the components of the sepsis 6 are. So here is the venous blood gas. I apologise as my recording here is covering the normal values for the potassium and the HB. But yeah, we can see that generally the lactate is fine. It's not raised, which is good. And the patient's glucose is a bit high, but she's diabetic, and it's still that's fine. The patient's sodium is raised. If you remember from the bloods before, it was 146, so she's even more dehydrated now. And the potassium is fine, and her haemoglobin is still on the low side. It was 102 3 days ago, so it's still on the up, and that is absolutely fine. So the urine dipstick, this is what it looks like. These sticks, they come in these tubes and then they've got how to interpret them on the side very, very easily. So it is a stick with different patches on. It's dipped into the urine and then the colours that they indicate will tell you whether or not there's white blood cells in there or red blood cells or glucose, etc. We'll go over how to actually interpret it on the next slide. So the nurse comes over with the patient's urine dip and she tells you that there are some red cells in there, more white cells in there, it's positive for nitrites, there's no ketones, a tiny bit of glucose and no protein. What does this mean? So urine dip interpretation, it's really simple and it's something that you should be aware of. So reasons that you may have red blood cells in the urine, so they're commonly present in infection and kidney disease. In females of a certain age, you need to check whether or not they're on their period because it could be due to that. However, if it's in an older patient, it does always need investigation because it can be a sign of a bladder or a renal cancer. If there are leukocytes, so white blood cells in the urine, sometimes they're present in infection, but they can also be present if there's inflammation. So if a patient has a catheter in or has just had a catheter removed, the area will be inflamed. However, together with nitrites being present, that would indicate an infection. And this is because, so nitrites are a product of bacterial metabolism. So if they are there, that means that there is bacteria in that urine and the patient has a UTI basically. Ketones we'll be looking for in diabetic patients can be a possible symbol of if they have diabetic ketoacidosis, which can be a cause of a patient being unwell. And that's because the body can't use glucose for energy, so it goes into ketosis. This patient does have a little bit of glucose in her urine and she's hypoglycemic, maybe her diabetes isn't very well controlled. Protein shouldn't normally be seen in urine, and there isn't any in hers, which is good because this normally indicates kidney disease, because that means that they're leaking out of the tubules and they shouldn't be. Okay, so management of this patient. We've done the sepsis 6 and she's had a senior review. Patient seems to have a UTI that is likely the source of a sepsis. So we've already instituted some aspects of the sepsis 6. So IV antibiotics wise, we want to check your local guidelines on that microguide app, and I had a look at what I would give, and I would be giving this patient a stat dose of IV gentamicin. We would send that urine off and we would see what it grows, so then we would get a bit more of a directed antibiotic therapy as well. So we want to give the patient some IV fluids going on in the background, so we'll calculate how much she needs by her weight. Please see the fluids talk as to how to do that, and she also needs a fluid balance chart and a catheter. We want to check her remaining bloods. Like I said, they'll take a couple of hours to come back, but someone needs to check them. So either if you're finishing your night shift, let your daytime colleague know that they hopefully will be back at some point in the morning, and they need to be looked at for any other abnormalities. And as I said, the urine will be sent off to the lab, and the report's usually available after sort of 24 hours, or 48 is the normal, just to see if it's growing any other sort of microorganism and what antibiotics that it's sensitive to. Okay, so now we're just moving on to case 2. So you're now on call and on days, and it's 5 o'clock in the evening. A patient's come back from recovery today, and she's had a bisagittal split osteotomy, and she's now breathless. Please, can you come and see her? So this isn't, again, not been given very much information to kind of recreate the likely sort of phone calls that you'll be having. So you need to be thinking about, what else would you like to ask the nurse over the phone? So you'd want the patient's full observations. We want to know when those were taken. And also, where is the patient? There's no details here. They haven't told you where she is. The nurse hasn't told you which ward she's calling from either. So that's really useful information that you would need to know, because you need to know where you're going. So we have a little look on the system, and we can see that we've got a 25-year-old female called Zara. She had a BSSO this morning, and she has a past medical history of asthma. She takes salbutamol and beclomethasone inhalers, and also a medication for asthma called Montelukast. She is allergic to dust and animal hair, and she currently smokes 10 a day, doesn't drink any alcohol, works as a civil servant, and lives alone. So your nursing colleague has kindly taken some observations for you. So her saturations are 94% on room air, which are a little bit low. Her respiratory rate is 23, which is definitely high. She's got a normal temperature. She's tachycardic, so her heart rate is too high, and her blood pressure there is normal. So you go and see Zara, and from the end of the bed, you can see that she looks a bit breathless. She's breathing a bit faster, but she is alert and she's able to speak to you. So it's worth, in this sort of case, taking a very, very brief history. So Zara tells you that she's feeling breathless. She's been coughing quite a lot today because she's been struggling with excess saliva, as patients often do after they've had a Biomax or a BSSO, because everything's quite swollen. But it is a dry cough. She's not been coughing up any green sputum or anything. She hasn't used her inhaler today because her face is quite swollen and it's too painful. And she also feels like she's got a bit of chest pain on the right-hand side. She says she has felt breathless, and this has kind of happened before. She was actually hospitalised last year for a couple of days because she had an asthma attack. So it seems like from the first bit of our assessment we have a breathing problem, and like we said, we like to fix the issues as we go along. So she has low saturations and she's breathing fast, so she needs that high flow oxygen. So we definitely also need to be taking a chest x-ray and an arterial blood gas because her saturations are low, so we want to have a look at what the actual partial pressure of oxygen is in the blood, is she retaining carbon dioxide and that sort of thing. We do know that she's got asthma, so it is possible that she's having an asthma exacerbation because it's not well controlled, which we know because she was hospitalised last year with an asthma attack. So you can start treatment for an asthma exacerbation because it will help in one way or another. So you can give her a salbutamol nebulizer. Like she said, she can't use her inhalers because her face is swollen, it's too painful. So we give that through that oxygen mask with the high flow oxygen, and we want to be rechecking her breathing and her saturations continuously to make sure everything is improving. Because her heart rate is also high, we want to be getting an ECG to rule out any other sort of pathologies. Her blood pressure is fine, so she doesn't need a fluid bolus at this point, but we might need to think about it because we're going to keep taking that blood pressure and checking that she's not deteriorating. We do need to take some bloods, so we'd want to take for this patient an FBC, some Usinese, a CRP, and probably some liver function tests as well. Checking her disability, so she's alert. Her glucose, we took that arterial blood gas, the glucose will be on there, and so we'll have a look at that. And her pupils are equal and reactive to light. Having a look at the rest of her calves are soft, they're non-tender, they're not swollen. Her abdomen's soft and non-tender. The operative site, as you would expect, there's no sort of issues there, and there's no other signs of any other abnormalities elsewhere on the body. So the arterial blood gas comes back in a couple of minutes. We will have a talk on how to actually interpret these, but as you can see, I've not highlighted anything red, so everything is pretty normal. So we can see the patient's observations have been improving on that oxygen, and your reg is on the way as well. But we would want to have this to hand to show your reg when they get there. So we have a breathless patient here with a history of asthma, and her SATs and her respiratory rate has improved with oxygen, but it's still not quite normal. The ECG comes back, your reg looks at it and says, okay, her heart rate is fast, but again, there's no arrhythmias and it's normal. And so even though I said at the beginning that the A to E assessment is to treat the life-threatening issues and to buy some time, it is always good to have a little bit of a think, what is actually going on with this patient. So let's have a little bit of a think about what are the causes of breathlessness. So some differentials, the most obvious one here would be that this patient is having an asthma exacerbation if she has a known past medical history of asthma. She could have a chest infection. She could have a pulmonary embolism, a PE. She could have a collapsed lung, and it could also be cardiac. So patients sometimes, she was also complaining of chest pain. We know she's young, but it does happen. It's very rare. She could be having an MI. So your registrar comes and examines this patient and also has a listen to the chest and taps all over the area. So her respiratory rate, as we said, has improved slightly to 19. Her SATs are now 96% on that air. Her chest is expanding equally. The trachea is central, but your reg says she can't hear any breath sounds in the right upper zone. And it's also hyperresonant to percussion. Now, I wouldn't expect you to recognise the diagnosis from this description, but this case that I've put in here is, so basically this patient is not having an asthma exacerbation. It's to illustrate the simple fact that those interventions are important no matter what the diagnosis is. So if the patient was having an asthma exacerbation, we would expect her to sound a bit wheezy because, as I said earlier, the bronchioles narrow and that sound of the air travelling through gets higher pitched. The lack of the breath sounds indicates that there's no air getting into that upper part of the right lung, and hyperresonance mean that when your reg has tapped on the patient's chest like this, the pitch sounds higher compared to everywhere else. So this is a sign that there's more air in their in comparison to the rest of the lungs, which is abnormal. So we've got a chest x-ray, and we don't expect you to be able to interpret chest x-rays, but knowing what pathology you might see on them is useful. So we do take chest x-rays for patients who are breathless to look for any fluid in the lungs, any what we call consolidation, which is a radio opacity that can kind of indicate pneumonia, or any lung collapse. Now, if you look at this, I've picked a very obvious example, so I hope you can see the right lung What we call the lung markings don't go all the way out to the peripheries. So there is a very obvious distinct line that you can see, and that is an indication of there is air in between the chest wall and the lung, and this is what we call a pneumothorax. So the medical registrar comes over to review Zara, and they advise that they are going to aspirate the pneumothorax. So it doesn't sound very nice, but they basically just stick a big needle in with an empty syringe and draw out the air. They say to us that we're going to continue our normal post-op management, but they will come over and monitor the patient as required. So last case now, thanks for sticking with me. So you're back on nights again, and you've been called to A&E to see Ray, who's a 47-year-old male with quite a big scalp wound. The patient was slashed with some sort of unknown object. He was bleeding at the time, and the paramedics very helpfully put a big pressure bandage on his head. They tell you that he's otherwise fit and well. He's got no known drug allergies. He doesn't smoke, and he drinks about 40 units of alcohol a week. And they've managed to get his observations for you. So his temperature is normal, it's 36. His respiratory rate is a little bit raised at 20. His oxygen saturations are 99% on room air, so they're normal. His blood pressure is quite low, it's 84/69, and his heart rate is 127. Now, if you remember back to earlier on in the talk, I said that there was a term that we use for patients who are not really managing to maintain their blood pressure to their end organs, and that term is hemodynamic instability. And like I said, it is urgent and it needs addressing quickly. So you go to A&E to see Ray, and from the end of the bed, he's alert, but he is agitated. When you're assessing his airway, he's able to speak to you in full sentences, and there's no additional noises, and there's no kind of signs of any impending airway obstruction, no swellings or anything around the face or the neck. Having a look at the breathing, so there's normal breath sounds, his chest is expanding equally, he is breathing a little bit faster, but his oxygen saturations are fine. His circulation, so his capillary refill time is 3 seconds, but his hands feel a little bit cold. His heart rate is 124 and it's regular, so he's tachycardic and his BP is low. So this patient isn't managing to maintain his blood pressure, and that does need immediate management. So Ray needs a fluid bolus. As far as we know, he doesn't have any heart or kidney failure, so we're going to give him a 500 ml bolus of fluid over less than 10 minutes, and then we're going to recheck that blood pressure after to make sure it's come up. Because he's got a high heart rate, we want to get an ECG as well. And bloods have already been sent off, but you can also take venous blood gas to look at those immediate parameters like we had before. So the main issue that Ray had was a circulation issue. So going back into this in a little bit more detail, we want to be feeling for the pulse at the wrist and noting whether or not it was regular or irregular. His blood pressure, as we said, abnormalities do need to be taken in context with the usual readings and the clinical condition, but that blood pressure, regardless, was low. So that's why we've chosen to give him a fluid bolus. Like we said, we want an ECG taken, and there'll be lots of A&E doctors luckily around to interpret that and tell you whether there's a problem or not. If he doesn't already have a cannula, we would want to cannulate him, and he would need that for the IV fluid bolus anyway. So finishing off our A2E assessment, we know the patient is alert. The glucose, we've taken that venous blood gas, it's coming, and his pupils are equal and reactive. Having a look at him, the calves are soft and non-tender, the abdomen's soft and non-tender, and he has a big pressure bandage around his head, and you can actually see that there is blood soaking through. So the great thing about A&E is there's plenty of doctors around to help you, and the A&E registrar comes over. He can see that the blood pressure has improved with one bolus to 92/74. It's still a little bit low, so we're going to give another one. And that venous blood gas comes back, and you can see that the patient's hemoglobin is 121. The normal values for an adult male is 130 to 180, so this is a little bit low. So we take the pressure bandage off, and this happens. So we can see that there's obvious active bleeding, and the bleeding is going to be the cause for the patient's abnormal observations. So if you remember, he was hemodynamically unstable, he was tachycardic, and his blood pressure was low because he's lost blood, so the body is trying to pump around the same amount of blood to maintain the perfusion to the organs. And his hemoglobin as well has dropped, again, because he's lost some blood. So this is obviously a very extensive wound, but there are some bits and pieces that you can be doing in A&E whilst we're waiting for the registrar to come in to help kind of manage some of the bleeding. So the patient is likely going to need to go to theatre, so you want to call the max fax reg and just let them know. If the bleeding can be stopped in A&E, then this can be delayed till later on. But if not, the patient would, we do need to stop that bleeding. So you can give local anaesthetic. It contains adrenaline, which causes vasoconstriction, and that will hopefully help. Other local measures that we can do, if you can see where the bleeding point is, you can apply pressure, and you can apply pressure with gauze that's been soaked in either tranexamic acid or adrenaline, because again, that will cause vasoconstriction and help slow down the bleed. Over time, you will hopefully get some experience in using this piece of equipment called a bipolar, which is basically an electronic cautery device. And if you're competent at using that and you can identify, bleeding points, you can take a bipolar from theatre down to A&E, and you can cauterize those areas of bleeding. It's really important that the patient's observations continue to be monitored, because if the patient's blood pressure continues falling, then we would need to be putting out a major hemorrhage call. And that's when they would send blood and various other things to help stop the patient from bleeding. So that was a bit of a long one. Thank you for watching, but here's some really important take-home messages. This is probably one of the most important talks as part of this whole series, because knowing the aspects of the A2E assessment and being able to perform it, without even really thinking is really important. You need to know to call for help early and know what the patient's observations, investigations, or history are to be able to tell your registrar or the medical registrar. Where you can, I would practice doing an A2E assessment in a simulated environment. When I first started my SHO job, we had a registrar who would make us do an A2E assessment on a well patient, but just so we got used to doing it and in the habit of it. So definitely practice on each other. And to be suspicious, as you've seen from some of these cases, things aren't always as they seem. And you shouldn't really be ignoring any abnormalities in observations, or if the patient seems unwell but their observations are normal, they still need to be assessed thoroughly. Here are some useful learning resources. All of these books or websites contain how to do an A2E assessment with some worked examples. The Show Me app also is a very handy kind of thing that you can have on your phone to look it up very quickly as well. So thanks very much for watching. If you've got any questions or any feedback, please do drop us an email at omfssurvivalguide@gmail.com or fill in the feedback form below. We would like to know what we can improve upon continuing the course and everything. And do follow us on Instagram to learn about our future courses and some flashcards to hopefully help you through the job. Good luck.